very short period. Just allow me only a very, very brief question, yes, before the commentators will start on. I was pondering, do you feel a bit old-fashioned after all these new transcatheter valve, new techniques and therapies?
Old-fashioned maybe, but it's the the results of our techniques they have the transcatheter techniques. They haven't given better results. We will always have young patients to treat, and the surgeons should never lose their core surgical skills because even if all aortic valves are treated by transcatheter methods, at least 30% of the aortic valve will still be done by open heart surgery.
Great. Yes. Okay. This is the reality at the moment. Yes, but just my feeling is that already mechanical valves sound a little bit old-fashioned already.
Yes, but
mechanical valves.
Yeah, a few days ago at my clinic, I had to see a patient that was 88 years old, had put a mechanical valve 30 years ago, but still it's
at the moment.
Yes.
Since the durability will change, everything will change. Anyway,
yes.
Let's start from the ladies first. Dr. Mavrogianni, you are one of the commentators. Please make your comments.
Yeah, good evening, everybody. Excellent talks, everybody. I think the technology is already there. It's the first time in our practice that we're going against all valves, full frontal attack, and it's going to get better and better. Mitral clips are going to get better, mitral manipulations are going to get better, pulmonary artery is there, tricuspid is there, TAVI, there's no question about TAVI. We've been manipulating the aortic valve for 20 years now, but I don't think that's not quite the issue. I think the issue is that through all these manipulations with the valves, we have gained tremendous insight on the pathophysiology of the valves, and therefore we know now, not quite clearly, on which patients to intervene and when. And I think that is the big question and what we are aiming after.
Yes, of course.
Thank you very much, and it was an excellent presentation. I have basically a comment and question at the same time, and it's not only for this presentation. As the indications broaden and include younger patients that you mentioned, and for example bicuspid valves and transcatheter valves, one question is the durability, and the comparison would be fair to be with bioprosthetic. So what's the 5-year durability or 10-year durability? And the second common question is regarding the, for example, I've seen personally patients in their 40s and 50s who have done TAVI out of preference in the United States. And these patients, if they need reintervention, okay, valve in valve we know, but surgically, is it possible and is it feasible to do a surgery after TAVI?
It is feasible. It's a very difficult operation. At some point, you'll have to replace the aortic root. It will be a bendal operation. It's very difficult to extract the transcatheter valve implanted. It's already part of the aortic wall. It's very difficult to take it out itself and just replace it. On the other hand, when you do a redo surgical salver for an old valve, it's much less difficult. It's easier, and in most cases you don't have to deal with the root. So it is feasible, but it will be a difficult operation with a high-risk operation with a high mortality risk.
Great. So we have to move now to Dr. Pipilis. Comment?
Okay, since we have the surgeon here,
okay.
Let's start from the last event to answer the comment of Professor Vardas that the mechanical valves are definitely not obsolete, and I totally agree with you. There's place there, and pharmacology is improving its anticoagulation, and perhaps factors aiming at the 11A factor might be also a solution, because they block the contact pathway of coagulation, have minimal bleeding risks. They're being trying in many trials now, first in atrial fibrillation. It's a field that will be expanding, and it may revive the new valves with minimal anticoagulation for young people. So that's something that won't be obsolete, I'm certain. In terms now of comments for the whole session, if I may, we heard how the technology goes fast, and all the advancements are impressive, and we can't predict really the future because it comes faster than we think. But in terms of clinical medicine, what we need to be better, it's to see how the indications are expanding towards younger people and more early phases of the disease. So that's one thing which we'd like to have more information when we're advising our patients. And also, if we are in a position now to have a very personalized approach, which procedure is for which patient, and that's where perhaps the favorite topic of Professor Varda's AI might be helping. Iulia Grapsa had a very beautiful comment on that we need to be very precise in prediction of the degeneration of the valve. So that's what we really need in the future, to be able to say, so that we can advise the patients on what to expect from their transcatheter procedure, what to expect. And if we're very precise on that, then that's a major advance for the future. These are some comments, and perhaps would like to know what the speakers think about the prediction of if we're in a state to predict the durability of the valves at the moment, or would we expect something apart from technological innovation that are moving towards biotechnology?
Great. So, Doctor.
It is important that we have traveled that far and still have a lot of refinement to do by means of patient selection, delivery systems, imaging, fusion imaging, and of course, if we have proper imaging, AI can help us have more predictable procedures. I would like to ask you something. Do you think that with this synthetic non-metal valve, we could have a game changer and stop the expansion of TAVI to younger populations?
I think that according to the designers of this valve, they think might be a game changer. It will have great durability and not need for any anticoagulation. But of course, it has only just implanted in very, very few patients, 3 patients so far. So larger clinical trials with larger scales should be run on this. But I think the future goes. I think that will be the future.
But this material is a customized one, is it?
Sorry?
This material is using the polymeric one is a customized.
It's not yet. It's not in the market. It's still in the trial.
In the market.
But they have already been implanted in humans. They have taken this. They are allowed to do that, and they are trying to put it in a larger study now.
Okay. The idea is it has a much easier molding, so it will be both cheaper probably,
yes,
and customizable. So it's
could be custom made for each patient.
But I would like to make especially address to Dr. Spagias. Very simply talking, it is a matter of durability nowadays to use all these devices in middle-aged patients, or is the stability of the valve? Is mostly the durability of the fabric used? This is my naive question, because if the problem is the durability and the fabric, I'm very optimistic that the science of materials will solve the problem.
I think, as you've heard from all the speakers today, there is work done currently at multiple levels, not at just one level. and we had 4 excellent talks, state-of-the-art talks. I was really impressed by all of them, and they were all to the point. I think the problem now becomes, for cardiology, we are lucky because we don't have differential diagnosis problems in our specialty, so the diseases are counted in the fingers of one hand. But now we have very complex treatment algorithms and therapy algorithms. As you heard, even for surgeons now, it's not just a aortic valve replacement. Is it sternotomy, J-sternotomy, robotic? So it becomes very complex. The durability issue is just for the TAVI valves or the mitral valves when they come into market, or the tricuspid valve. So in the valve replacement, yes, the durability of the leaflets is an issue. Certainly it's as good, I would say, as the surgical leaflets in the biological valves today. I don't think there is any difference.
So, please.
Let me try to add some more information in Dr. Vada's question. It's not only a matter of durability, but you have also to solve some other problems, like the increased need for a permanent pacemaker, and how will this affect the survival, and also the PVLs. These are I think, the 3 major drawbacks for the use of TAVI technology in this age category.
Yeah,
okay.
Of course, we cannot speak for all the kind of the valves. I would like to focus on the TAVI issues, okay? It seems to me, which TAVI is really, if I have understood well, because I'm not a specialist, the easiest of these discussions, like tricuspid and mitral. The stability, etc., of the mitral solutions is a bit more complex. But talking about TAVI, I'm very curious to understand, is only the stability of the valve and mostly the durability of the leaflets to make this valve living forever? I don't understand, because if the problem is the fabric, if the problem is the durability, I am extremely optimistic that the science of materials will solve the problem. Come on.
It's not only, Dr. Vardas, it's not only the comparison of material between surgical and TAVI valves. It's the local condition.
Okay.
Dr. Roussakis is cleaning the aortic valve. He's living, after the operation, he's living absolutely clear sinus of Valsalva, but this is not the issue for, unfortunately, for TAVI.
Yeah, nobody doubts that the open chest, even restricted sternotomy, makes clear job. Nobody does. But on the other hand, everybody likes to avoid the scars. This is the problem.
Yes.
This is a general comment, a little bit more philosophical comment. Unfortunately, we have no time. We have to move to the next person. Nikos, yes, you deserve your question.
Something different from this future development. It's about medicine. There is no medicine sequence preventing or slowing the progression of calcification. So possibly we can find the medicine taking this and then no calcification. So
we have to speak about inflammation pathways.
Yes, it's, I think it's under. In USA, if you take it for 6 months, they found that the calcification is...
There was a publication on this recently, on a new drug.
Great, thank you very much.
Thank you.
All of you being with us today, and we have to move to the next one.